As we push more towards patient centered care in our industry, there are certain things we need to start changing in our practices. For so often, the manual therapy professions have been using something more along the lines of the clinician as the expert model. And this is where a patient comes in and they have a certain expectation where we determine the cause of their problem, develop a treatment plan, and they have that certain confidence that we can remedy whatever issue it is they're dealing with. But doing things this way isn't really including the patient in the process, nor does it give us much insight into their lived experience. So, part of what we need to do in shifting to more patient centered care is to start including the patient in what is called a shared decision making process and encourage power sharing in our therapeutic relationship. Now, there's a lot to this process. And if you're committed to having a better patient centered care in your practice, well, keep on listening. Hey there, I'm Jamie Johnston, and you're stepping into a new era of thriving as a massage therapist. We're embracing who you are, pursuing what you love, and confidently shaping your practice. We'll challenge industry norms, spark change, and discuss what truly matters. Things like mental health, evidence-based practice, and some topics we've long avoided. Let's create better outcomes for our patients and happier, more fulfilling practices together. Welcome to the New Generation Massage Therapist Podcast. Okay, everybody, we're here today with an old friend, Walt Fritz, who I've known for, I think, 10 or 15 years or something like that now, Walt. Just meeting through online things and in person at some courses. So why don't you give us a little bit of background about you?
Oh gosh, I've been around the business a long time. Jamie, I think I first meet you in Vancouver at one of those things. Yeah, I can't remember the name of that, but yeah, that was a fun
RMTBC
one.
conference.
Yes, thank you. But I've been a physical therapist since 1985. Manual therapy is, I mean, it's what I do, it's what I teach, it's kind of what I specialize in, both as a clinician here in my office in upstate New York, as well as traveling and teaching. My background is myofascial release. I mean, I was one of the guys, the inside club guys of myofascial release, and then I had the audacity to leave that model and start publicly questioning it, which it created a lot of I guess a lot of friction in that MFR community. But I know a lot of people actually appreciated the dialogue, the narrative of, why would you question something that's so effective? Why would you question something that's given to us by this guru type of educator? And to me, it was pretty simple. It's like, you know what? There's more to life than just fascia. So, and now I sort of, well, over the last 6 years, kind of veered off on a slightly different path. Prior to COVID, the beginning of COVID, I was teaching pretty much half and half, classes to massage and physical therapists, as well as classes to speech pathologists. But during that early COVID period, I had a really good chance to sort of regroup and take a look at myself. And I decided to make a shift. And now the only classes I teach live are my voice and swallowing disorders classes. I get a wide range of therapists attending those. It's not just speech therapists, speech pathologists, but I don't know. I found a real freshness in that new community. And honestly, Jamie, they didn't have a lot of really bad habits that were sort of instilled from them by sort of those closed concept multi-tiered trainings that, I mean, let's face it, you and I, that's kind of our bread and butter on how we learn this work, right? Yeah.
Totally. Which is very interesting because like looking over some of your articles and things like that, looking one that I found, you talk about that approach or that old narrative approach of being the clinician as the expert model. And I find it really interesting to come up with that as sort of a label, because that's what many of us were doing and many of the instructors were doing, was that they were this huge expert that, you know, you had to do whatever they said. And it's awesome to see the transition that you've made. But what I find interesting is, like, when we're taking that approach, we're not genuinely getting informed consent from our patients when we're using the old narratives of the, you know, I'm releasing your fascia or whatever like that. And I'm just wondering if you have any thoughts on that around, like, actually getting informed consent when we're using that older model.
Yeah, I think it's a really valid point, Jamie, because I don't always think of it quite that way in terms of the informed consent piece, but I know that As soon as you said it, it resonated really well. Patients or clients, whatever you call your people, they have a tendency to sort of hand over power to us. We're
Yeah.
an expert. Nobody's helped them, and you've been told to me you're the guy, right? So I trust you. Do what you think is best for me. And well, I understand that model. It's basically part of medicine and healthcare in general, in terms of how that division of power or separation of power happens. I think it also puts the patient in a rather vulnerable position where, yeah, we haven't really gotten that clear, informed consent from them. I believe strongly in boundaries and permission, staying within our boundaries, which again, I don't want to get too inflated or inflammatory here, but in a lot of models, boundaries are easily crossed,
Yeah.
in terms of, especially when it comes to emotional, somatic type works where we're taught that, oh gosh, I was taught that, until the patient comes to terms with their emotions, they're never going to truly deal with their pain. And it's like, boy, that's a fine line between, being a physical therapist, being a mental health counselor.
Yeah.
And now with the onset of trauma-based therapy, I think there's some really good ideas and concepts that are being taught, but I also think we're missing some of the granular piece down low is, what should we be doing and what should not we not be doing? What are allowable techniques and what aren't? And I don't want to ruffle too many feathers, but I was taught a lot in my myofascial release training that I look back and say, boy, that's a huge boundary inflection, in terms of what we did, what we said, etc. How we lay out our website, Jamie. I mean, if you ever go to an expert's website and it's all leading you down the path of, well, stick with the fascial model, right? It's all about your fascia. People don't know about fascia, right? That's what they say because we've heard it, so we repeat it, we regurgitate it. It becomes a shrine to the guru that we learn from. And there's value that can certainly draw public in, but can you know with 100% certainty that this person's problem is their fascia? And can you know with 100% certainty that you're releasing it, whatever that means? And if
Mhm.
not, I don't know whether we're really clear on that informed consent piece.
Yeah. And which makes it also difficult because when we're using descriptions like that, it's also giving the patient something to blame for
Yeah.
their pain, right?
Yeah.
Because they're going, oh, it must be my fascia. I got to go get that released, or
Yeah.
whatever the technique is.
Yeah.
We're not just picking
Exactly.
on fascia. It's,
Exactly.
it could be that, oh, I need to go have somebody do this to my tissue in order to feel better. So it's good to see that many of us are starting to make that transition and making the change.
Yeah. In
Um,
fairness, though, I mean, that's part of the sell, right? It is part of the sell, and let's face it, we are selling our services. But I think there's more ethical ways that we can do that. I still get patients, even though I let go of those words myofascial release 6 years ago now, I still get patients who said, you know what, my doctor or somebody else said that you're the guy for fascia in the Rochester area. And yeah, over time, I sort of soft pedal that's changed a lot. But I do think it's important, Jamie, not to fracture elements of the therapeutic relationship. If they feel that we're that person, right? I want to be very clear on the boundaries, et cetera. But I also don't want to just sort of step on a story that they've really sort of become accustomed to and feel is their missing link to pain relief, that sort of thing. It's a real fuzzy area that I don't know that a lot of us are taught that. I was teaching a class overseas earlier this year, and on the second day, a therapist sort of not interrupted me, but she said during a break, you're teaching us the soft skills that we're supposed to know, but nobody really teaches us, right? And I thought that was really insightful because I never really sort of looked at the way I approach this work from a shared decision-making perspective, that it's the soft skills. And I've got a really interesting paper if you're interested later, Jamie, about this on metatherapy that really describes those soft skills and the need for those really well.
yeah, and I started to make a shift there too because they're like I've gone away from calling them soft skills because they're really hard skills, and I'm
Yep.
actually starting to call them more human skills
Yeah.
rather than a
Yep.
soft skill.
Yeah. And I think that's probably an even better way to put it, right?
Yeah, yeah,
Yeah.
because we're treating that human in front of us, right? So how we connect with them and how we talk to them and all those different things that make such a difference in a treatment.
Exactly. And if I could just, I'm just going to get rid of this one already since I just wrote it down and I don't want to forget that. But
Sure.
I was doing a podcast, not a podcast, but a meeting. I was invited to do grand rounds at the University of Pittsburgh Medical Center, 2022, and it was a group of ENT surgeons and speech pathologists, and they wanted my whole take on treating, using manual therapy for voice issues. And I was sort of going through the concept of, yeah, we use these techniques to help with that, but we're really trying to get the patient more involved via shared decision making. I was kind of describing loosely my shared decision making model, and one of the clinicians stopped me and said, "Hey, have you heard of metatherapy?" And I hadn't, and she said, "Then let's talk later." So we separated via another Zoom later on, and it was a researcher by the name of Lea Halou. Lea Halou is a PhD speech pathologist who has written extensively on a concept called metatherapy. And the way
Okay.
she describes it is the therapy is what you and I do, right? Whether it's a exercise or a cognitive behavioral intervention or a manual therapy or a massage type, it's the technique we're using. But what she described was the meta that surrounds that therapy. And the meta, in her view, was possibly equally impactful, if not more impactful, than the technique itself. And what she did in her research was she took a look at two clinicians. One was a brand new grad, and one
Mhm.
was a more experienced clinician. And they were using specific voice techniques for a voice disorder. And I won't go into that for the sake of this, but anyway, what she did was she observed the new clinician using the technique, and they did everything properly. They did the technique exactly how it's taught. And then she compared that to how the technique was applied by a more experienced clinician. And what she saw was that skilled clinician did the exact same thing with the technique, but how she enveloped that technique was very different from the new grad. The meta that surrounds it is our language, our understanding, our relatability, the context that we figure out to apply it in. And yeah, it comes from mentoring, from experience, from education. But what she was describing was to me, and the reason she interrupted me at that point, because she saw my shared decision making model falling right into the metatherapy model. That we think it's the skill of isolating the pterygoid when we're trying to do a jaw technique, right? And it certainly is, that's important. But it's the context that we ground that technique that really becomes more important. And to me, I accomplish that through shared decision making, meaning, Jamie, what I'm doing right now, does it feel like I'm doing something that might be productive? Is there anything about this that feels like it could be threatening or harmful? Or does it feel like a big waste of time? Is there a place you'd rather have me go? So I'm using techniques as I learn them, and MFR and all these other classes over the years, right? But we're sort of handing over, not handing over, but opening up the window to power sharing with the patient. And I know I'm going on a little bit here. I apologize, but I
That's
linger.
okay.
I lurk on a lot of massage groups on Facebook, especially. And one of the repeating themes that I often see brought up is people, therapists complaining. How do you deal with the micromanaging patient, the patient who wants to control the session, you know?
Yep.
And to me, it's like, I want my
Let
patient
them.
to let the, yeah, to have me tell them, no, you're not quite on it. No, stay there longer. No, it's time to move on. But a lot of people feel that that's a real infringement on their expertise. And I think we've got that backwards. I think that's that patient telling you how to help them better.
Yeah, and it's interesting, like when you look at both ends of that, because the like you look at some notes that you and I shared is that success breeds confidence, and you've got a therapist who's been successful for a while and it breeds confidence, and then they've got that person in front of them who wants to take more control of the therapeutic dynamic,
Yeah,
but their success is maybe telling them, no, I should, no, this is like, I'm the expert, so we need to listen
yeah,
to me.
yeah.
So how do we take that and make that shift in the power dynamic to 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 take it from that person who maybe doesn't want to make that change, but should make that change and understand how to hand that power over to the patient.
Yeah, I think the should is difficult, right? Because if you have a successful clinical practice, being the expert clinician, why would you want to change? And I'm not in the model of sort of beating people up to say you can't keep doing that.
Mhm.
If it's a successful model and your patients are happy with what you're doing, fine. I think no, not think. I know that one of the reasons I like teaching the class for speech pathologists is because I'm not getting experts in the room. I'm getting experts in speech pathology, but they're beginners when it comes to manual therapy. So I can sort of bend them in the direction that I want, right?
Yeah.
Which is shared decision making. But the cool thing is that from their perspective and from your perspective is shared decision making applies no matter what you're doing, whether it's manual therapy or massage or myofascial release or exercise. I use an exercise-based approach for teaching patients exercise. If the standard exercise that's supposed to be good for your biceps isn't quite resonating from peripheral to central, let's modify it to until something feels like, oh, whatever we just changed, that feels more useful. You're sort of having a conversation with my pain, my weakness, whatever that is. So I just offer it up as an option, one that really, I believe, at least for my profession, I'm expected to work from an evidence-based model. Those three basic components of the evidence-based model are the research, right? The evidence, clinicians' expertise and experience applying that good research, but that third circle, patient preferences and values. I love asking people, like when they're doing manual therapy, myofascial release, how do you account for that one third of evidence-based practice? How do you account for patient preferences and values? And there's a lot of sort of hesitation and stammering, and I'll hear things like, well, I ask them how the pressure is. And certainly that's fine. That's a fine starting point. But in the original model, that was one third of the weighting.
Hmm.
How do you elevate that to essentially a level where you and I, if you're my patient, so you and I are having a relative equality in power in this therapeutic relationship? And there's a lot of different ways that people have talked about how sort of elevating patient preferences and values. And I think shared decision making is a really good one. All right.
Yeah. Yeah.
So if you're expected to work, and in Canada, I know you have a lot different education program than the United States for massage therapists. Is the evidence-based model supposed to be a basic tenet of what you're working from?
I mean, it's been quite a while since I was in schools. I don't know how much they've updated it, but I know our college, like our regulatory body, is pushing that more.
Yeah,
That
yeah,
they want that.
yeah.
So,
And to
um,
me, it's a good thing to hang my hat on. It's like, okay, I'm giving you one way. It's not the only way. I'm giving you
yeah,
one way to at least see that, okay, I am honoring the basic components of the evidence-based model through shared
yeah,
decision making.
yeah, which is great because then how do you introduce a range of treatment choices to a patient? Because it's like a range of treatment choices isn't necessarily that I'm going to use a different technique with you. It can also be we're going to use some movement. We're also going to maybe adjust the time of the treatment and the frequency of the treatment and all that sort of thing. So how do you present a range of treatment models to a person so that that shared decision making is taking place in your treatment planning?
Yeah, so I work from a myofascial release traditional perspective. At least the way I learned myofascial release, there's a lot of different schools of MFR, right? Some are more a rolfing fashion, but mine's a slow lingering fashion. And I use a lingering fashion, number one, because I'm used to it, but not because of what I was taught originally, that if you don't stay in that hold for 90 to 120 seconds or
Yeah,
5 minutes, whatever it is now, that you're never going to release the fascia. I hold it for a period of time. So it gives the patient time to reflect, to feel, reflect. First of all, do I feel safe? And I think that's the basic component we have to get over first. Does this feel safe? And if they don't feel safe, they're not going to go to the next level of reflection, right? So I want to make sure whatever we're doing feels safe, and not just my pressure, but me, the situation, all the context that I've created here. Do they feel safe in my presence on my table right now? And until they get past that, we can't move into reflection. But reflection to me is where it really comes in. It's like, okay, I feel what you're doing, Walt, but it's not quite connecting with my problem. I use words like that, connect with the issue, whether that's making it more aware, right? Or calming it, quieting it, soothing it, right? I call it a continuum of relevance. I want to do something with you, Jamie, that I jump on that continuum. Now, where we go, one end to the other, that's for you and I to figure out, right?
right.
So that shared decision-making model of let the patient help you help them, right? In terms of my lingering touch perspective, it gives them time to relate and reflect. I'm not going to sort of weigh this conversation down, but I have a lot of research that takes a look at, for instance, the effects of continuous touch, not just on the tissue, but on central nervous system in
Right.
terms of brain centers, right? There's a lovely study in 2017 by Sarah Telly that took a look at the effects of continuous touch on the receiver, All right. And to me, my work is all about trying to get that patient's central nervous system to say, hey, whatever you're doing, this feels useful. Now, MFR to me, the way it was taught to me, it's not like I would say to them, no, you can't say anything to me. I'm the boss. I'm the expert, right?
Yeah.
But it was often done in silence, right? So we could let them go deep and reflect and relate and find their emotions. And is it relatable? Not that those don't have value, but my interactions tend to be more verbal in the way that, does this feel safe? Does it feel useful? Are we on the right spot? Would you like me to move on now, or would you like me to linger? Right.
Mhm.
So that's kind of how I arrange my sessions. And there's times when the patient says, no, whatever you're doing, stay there. I want you to stay there right now. And people will look at me and say, how, especially speech pathologists, well, how can you hold a technique for 20 minutes? And I'll say to them, because my patient asked me to.
Yeah.
They were finding value in it. And to me, that is good ethics right there, actually listening to what the patient is requesting without me feeling like, oh no, we have to do these other things in this session too.
And that's a contributing factor back to informed consent as well, right?
It
That's
is.
the consent that they're giving to you, that's what's feeling good at the moment and what is feeling effective for them.
Yeah,
So to go with that, quite often our biases will play a role in the technique we pick or different
strongly.
things like that.
Yep.
And I know you've had uh, gone over quite the bridge of dealing with your bias from your old narrative. So, like, how does bias influence our treatment choices when we're connecting with maybe a new person or somebody that we've seen for quite some time?
Yeah, now, I don't know, again, I don't know the exact scope of a massage therapist and RMT in Canada, but I'm a physical therapist. I'm legally allowed to use manual therapy. I'm legally allowed to prescribe exercise, right?
Yeah,
My website is sort of a weeding out tool in a way, because if a patient comes into me off the street, never having seen my website or heard about what I've done, and they look around my office and it's like, well, where's all your stuff? Where's all your machines?
yeah,
Where's all your TheraBand and all those things, right? So inherently, there's a bias because I lean toward a manual therapy type of approach. Over the last 5 years, though, I found myself sort of going back to some of my roots, using more of an exercise-based model. Not, I'm going to watch you do 3 sets of 10, but realizing that that movement, that exercise has incredible value. And I'm combining manual therapy with that, sometimes simultaneously, right?
yeah,
But I mean, I have strong biases the way I treat. I've got patients ask me, for instance, Jamie, why are you just holding a stretch? Why aren't you rubbing it? Why aren't you massaging it? And I say, well, because that's a lot of my training. And if you'd like, I can do that. I tend to lean into more of a static hold because that's what I've done and that's what I've had good success with. But I want to see if I can sort of modify what I do to meet your needs and values and expectations, right? So, I mean, we can't get rid of our biases. We have them, right? I
yeah,
think I think shared decision making is an integral aspect of what we should be doing. There's a bias right there, right?
yeah.
Other people are working as the expert and they see no need for that. Am I right and they're wrong? Not necessarily.
Yeah. And the thing is, the patients will have biases as well,
Oh
right?
yeah.
Because they could have gone to some treatment providers in the past that, they had some low back pain and a certain technique worked for them, and they might be coming in going, well, I know that worked for me before, so I want the same thing. And then
Yeah.
maybe we have to have the conversation with them, sort of like you were just having, that, well, this has been my experience and what I've done for a long time, and this is why I use this hold, but we can change and do some more of the things that you feel you like and incorporate that
Yeah.
in.
I mean, and bias extends to what the patients come in feeling is wrong with them. I mean,
Mhm.
that's part of their bias, right? And I remember back in the MFR days when patients came in to say, I'm having back pain because my core is weak. And I would
Right.
say, no, it's got nothing to do with your weak core. It's your fascia that's restricted, right? And they'd say, okay, that's an interesting approach. I've never heard of that. But I have also learned that it's really important from a therapeutic relationship and everything that that conveys, that it's really important not to fracture, to provide fractures in the therapeutic relationship. Because if we do, we lose credibility in the eyes of the patient. So what I've learned to do is not to be a slippery chameleon and change colors for every patient's belief system, right? But to provide a sense of validation to the beliefs that the patient come in with, even if I don't believe it's correct, right? No matter where they got it from, a past therapist, from their physician, from their, spouse, from Dr. Google, they all come in with an idea what's wrong with them.
Yeah.
And what I try to do is at least validate that, yeah, it could be that trigger point that your doc said that you're loaded with. Or it could be, just your nervous system is just loaded with remnants of injury from the past that it hasn't figured out a way to let go of. I tend to give them two relatively disparate narratives, one that they came in with and something set up on purpose to be pretty wide apart from what they said. And I'll tell them, there's evidence to support both of those. And I love saying this, that it first confuses people. Jamie, I may help you, but I may never know what was wrong with you. And
Yeah.
that's a tough one sometimes because we're supposed to know, right?
Yeah.
The more I learn, the more I realize I don't know a lot, I don't know everything, which
Yeah.
sounds odd from an expert with this many years of experience.
Yeah, yeah. Well, the I tell you, the more research that I read and the longer the tooth I get in this profession, the more I realize I don't know that much.
Yeah, yeah,
Yeah,
but it's fun because we don't have to abandon what we're doing. I didn't abandon my myofascial release handholds and everything. I just sort of evolved the narrative that I use to explain what I'm doing it and why I'm doing it. To
yeah,
me, mechanism of action is hugely important. And all of those rabbit hole therapies that we learn from, right? Those, where you're sort of clustered as a group and we're all learning about trigger points or fill in the blank, right?
yeah,
There's so much evidence out there that there's a lot more to it than just that single tissue story. And I have a cluster of those sorts of studies that when people start to challenge me on that, it's like, have you read these papers? There's a lovely paper that was written, it's like essentially by a researcher by the last name of Kolb, Kolb. And he's essentially saying, we know so much. Why do we continue to teach manual therapy from that pure mechanistic biomechanical perspective when we know we're treating a human being and not a dysfunctional tissue, you know?
yeah,
But as well as I do, a lot of that often falls on deaf ears.
yeah, yeah. And again, it's every technique, right? It's
Yeah,
we're
absolutely.
we're working with the person in front of us, not just the tissue in front of us.
Yeah, yeah.
Um, I wonder, do you have any steps that we can take to ensure that we're getting more participation from the patient
Yeah.
as far as shared decision making goes?
Yeah, and I find it helpful to sort of warn them. I do things differently.
Mhm.
I use humor a lot, sometimes maybe a little too much,
Yeah,
but I tell my patients I'm very needy. I'm a needy therapist because I need their help. Even though previous therapists may not have found that of value, um, the more I know about you, the more I stand a chance of helping you. So I do that on my website. I give sort of a synopsis of, here's my history, here's my present. I may be different, but the whole point of this is to see if we can do something that maybe somebody else hasn't done in the past. Um,
yeah,
if I can share with you a real quick story here, I had a
sure.
patient come in to see me a couple of years ago with some jaw pain. And she had seen a lot of different therapists, but she really bonded with a craniosacral therapist who she found the work very insightful, very helpful. She loved to be able to sort of drift deep into that emotion piece of what she was
Mhm.
feeling, how it related to the past and present. And if most of us have been there in various trainings, and I certainly can recognize that approach because I trained in craniosacral therapy as well. But for some reason, she left that person and came to see me. It's like, great, okay, so let's do this, right? So, I started my approach. I explained to her what we were trying to do, what the possible, in terms of informed consent. Here's the possible positive outcomes. Here's the possible negative outcomes, which I don't know whether a lot of people include those sorts of
Right.
conversations, right? But then I went to work. We did the standard pterygoid technique that I'm sure most of your watchers are familiar with, right? We put the finger between the mandible and the maxilla. And instead of me saying, oh, there's the pterygoid and I feel it's restricted and hot and ropey and a little bit vibration and all those things I used to be able to intuit in the past, I said, what are you feeling, right? Is this relatable? Is this familiar? Are we doing something that feels helpful? And, it's not that I kept her fully conversant during the whole session, but I kept checking in with her, kept checking in with her. So we finished the session and I said, how do you feel? And she said, that feels really good right now. Can I come back again next week? And I said, absolutely. So next week came and she came back and I said, so fill me in. tell me what happened between last session and today. She said, my jaw is still feeling really well. It still feels like it's looser with less pain. She said, but I really didn't like your therapy style. I didn't like how you never let me go deep. I didn't like how you kept sort of interrupting my process. And I'm saying, okay, fair enough, right? You're entitled to that opinion. So I asked her, would you like me to stay quiet during this session? She said, yes, please. So I did. I did it a little bit like a pouty child, right? Because it's like, okay, I'm now the expert who has to make decisions. So I remembered what we did. I remembered where we did it, and I did it again, right? Both sides, we did some other things, etc. We finished the session, and I say, okay, so how was that? I mean, she said to me, you never found the spot. You never found the spot that I needed work done. And I tried to sort of hold in my sarcasm, which is really difficult for me.
Yeah.
So at the third session, and she came back again, I said, can we sort of find a place to meet in the middle, right? She saw the value of the questions. She just hoped that somewhere within those questions, that shared decision-making aspect, that she could find her time to reflect and relate. So it was a nice sharing of decisions. And that's what it is right there. We're making these together. And it's not always equal. It never will be equal. Sometimes the patient takes the huge role of power. Sometimes they hand it to me, or I take it because they're not communicating, or maybe they're incapable of it, right? But she saw the value in shared decision making and allowed her beliefs to bend a little bit. And yeah, I bent toward hers too.
Yeah. And what I really like about that is like when I was first getting involved in, reading a lot of the research on pain science and then taking it and using it as an education process for patients, there was certain times that I would just vomit all this education stuff on people, and they're looking at me with this look on their face like, I just want to get on the table.
Yeah.
And then, as I got more experience, it was just like dropping little tidbits of information with each treatment, which, like, to me is what you did in that scenario, right? It was you start with one way, but then you shift a little bit of education each time until you come to a place where it's working for both of you.
Yeah. Because in a way, I mean, aren't we all like that? I used to do that with MFR, right? I wouldn't sort of like puke it all up at the beginning on them. We'd talk about that. I'd talk about the importance of their posture, and it's not good because of their fascia, right? And those are tidbits they inserted along the way. And I think that's a really good way to approach anything, whether it's your traditional clinician-as-expert model or a pain science model or shared decision-making model, right?
Yeah. Yeah, a little bit as we go.
Yeah.
So we've touched a little bit on like power transfer. And have you got any thoughts on why the transfer happens towards us so quickly with patients? Is it strictly just that they look at us as the expert, or is there other reasons why they look and want to shift that power when they come in?
Yeah, I don't know. I think that's inherent in the biomedical model, right? It's a built-in hierarchy where the patient knows less than the doctor, the therapist, whoever that is, right? And they easily defer to the expert. So they walk into our room, and it's reinforced if we've got a white coat on, by the way. But they walk into our room with a similar kind of mindset. And sometimes there are times when I do act like the expert because that's what the patient is expecting and really wants and seems to value. Not that I totally abdicate trying to get more out of that. But there are times when I do let them have their way, if you will.
Yeah.
I was doing another little one of these podcasts I was doing for the Voice Foundations of Southern California. Again, talking about manual therapy when it came to voice disorders, et cetera. And the two of the clinicians who asked me to do that talk had taken my class previously. And they asked me, just like Lea Halou did with her metatherapy paper, hey, have you read our paper? And it was on oh my goodness, self-determination theory was the whole approach, and it aligned well with metatherapy. It aligned well with shared decision making, but there was an aspect of it that really kind of threw me, that the patient has the right to say no, meaning the patient has a right to say to me, Walt, I understand you think my input is important, but I'm asking you to make those decisions for me. And that paper was another one that sort of it shifted the way I approached this. Because before that, I don't want to say I was browbeating my patients, but I was pretty insistent that they tell me what they're feeling. Does it feel useful, safe, all those things? And I've learned to temper that a bit, to step back from being so aggressive with it and allow them to say, no, Walt, please make these decisions for me.
Yeah.
Excuse
So,
me. Yeah.
so have you, what's a good way for us to change that perception with people who are coming to see us? Should we start right from our website and work back, or is it just on that initial meeting when they come in that you start to have a conversation or use some communication to change that perception?
Oh man, I think the website, I mean, most of us have a website of some form, even if it's a single page one. I'd say it's the easiest way to build in an understanding of who you are, right? I want my website to not create any surprises when the patient walks in the room. I have videos on my website so they can see me in action, to see my room, to hear me, to say, does he seem safe to me? Does he seem like he might be able to helpful? Right? I mean, these are aspects of it that people are doing essentially to check us out. But by pre-training them, it's like I do things differently. And I
Yeah,
am certain, Jamie, that there are people who say, nah, I don't like his approach. I'm going to pick somebody who sounds more like a trigger point expert instead of this
right.
more, he sounds more like a behavioralist instead of a physical therapist, right?
Yeah,
I stay in my lane, but I recognize the psychosocial aspects of both pain as well as intervention effects are meaningful. And I state that on my website. So no, I think I would rather not you waited until they pop in the room and all of a sudden you sort of pull the rug out from underneath them. Because, they might just want to get up and leave at that point. And by the way, with me, it's fine if they want to do that.
yeah,
I know, Jamie, that I lose some people now and then because number one, maybe I'm not working aggressively enough for them, right?
right.
That's one of my basic, the things that I refuse to do. Shared decision making doesn't mean I give up all power, right? But there's times when people are looking for a different personality, and I am absolutely fine with that because I'd rather have people that align better with me. I think therapeutic relationship is going to have greater context and value if we do have aligned values, right? And the website's a perfect way to sort of introduce that.
Yeah, awesome. So looking over some questions that you use, I know you've touched on a couple of them, but when you talk about like working from your patient's perspective, there's a certain model that you use. What are the main questions or comments that you like to use with the patients to help balance that scale to give the power to them?
Yeah. Well, first of all, I think this is going to sound silly saying this because it should be a given, but I listen to them. I strongly listen to them. I listen to how they describe their issue. The word they use or the words that they use, I think are really important that we stay within the framework of those words. Something as simple as me saying, so tell me about your pain. And they'll say, no, it's not really pain, it's more of an ache, right?
Yeah.
And and that seems and sounds so simple, but I write that word down so that becomes the word that I then I reflect, I mirror back to them, right? Whether it's during that session or a subsequent session. I want to know not just that they have pain or a problem, but I want to know how that affects their life, the quality of their life, right? Their relationships, their job, their all of those aspects. How does that pain, how does it impact you? How does it limit you? How would your life be different if it wasn't there? Right? I think those are really important things to sort of dig deep on, whether it's in that one intake where we're sitting there or
Mhm.
throughout the session. I I get a lot from my patients that I feel like you really value what I have to say. And I do think in a medical model, that's something that is not typical, all right? Because patients aren't the expert, right?
Yeah. 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 One question that I've seen you put out in an article is, and I've never seen anybody take this approach before, was would you care to put your hands over mine to better narrow in on what you feel is the problem or the solution?
Yeah, yeah. And that's something I learned a long time ago, really. I think that sometimes let's just use the face since it's visible here, right? I'm doing some work to the jaw and I'm doing it the way I was taught, which is basically to kind of, well, we were taught to compress and then decompress, right? And I do what I think based on whether it's the muscle orientation or the fascia, et cetera, or the nerves. I'm doing what I think is important, but sometimes the patient isn't quite getting it. So I could say, is there anything about this you'd like me to change? And they could verbally sort of talk me through a change, like maybe a little bit more force or a little bit more forward. And we can talk through that and me say, how's this? How's this? How's this? But to me, it's such a time saver as well as a context builder for me to say, put your hands right over mine and show me what you mean. And I love it when they do this. They take my hand and they move it, right?
Okay.
And to some people, that's really threatening because, hey, no, I know what to do, but I don't know this person. I love when they do that. And an instance that happened, Jamie, when I'm doing something like that, and I say, come and put your hands up here. And they put their hand over mine and they're saying, could you do me a favor? Could you take your hands off for a second and let me show you? And they put their hands there. And I realized that I just won the day because not only are they taking me to a place in space that resonates from here to here, I've also given them a really good idea on how to do their own self-care. Instead of being dependent on me, I want to make them independent. I want to get them out of my door as soon as possible and let them go live their life. And sure, maybe they can come back if they want. But to me, those are real value builders by having them participate with you. Sometimes I'll see the patient come up, they'll readjust me and they'll let go. And another time, a patient will come up and they'll just stay right there. And I absolutely love that.
Yeah.
Another tool I use that you may want to think about too, and I think it works really well with a slow static model, is by letting them put their hands here, and then I put my hands over them. And I do that for a number of reasons. Number one, if a patient seems to have any built-in fear of, well, is this safe to do here? Maybe it's post-surgical, maybe it's post-radiation, that sort of thing, right? Or
Yeah.
maybe it's just a severe issue that they're not sure about touch, even though they're here to see us for touch, right? By putting their hands first and then me working over, often what you feel with somebody who's got some fears is they'll start to resist you. They'll sort of wall you off. But then after a moment or two, where they feel like, okay, he's not threatening me, you'll feel them relax a bit. And basically, we start working through their hand, which is pretty interesting. But
Yeah.
then another step happens where instead of me just working with their hands passive, I'll feel them sort of participating as well. Now, I know this doesn't lend itself to all the different kind of models that maybe a massage therapist might use, but by adding that sense of safety where they have, I call it shielded work, right? They can put a shield up and not let you do something that they feel is harmful or potentially harmful until you've proven that you're safe, right?
Yeah. Yeah.
I love asking that question, does this feel safe or do I feel safe?
Yeah. There's so much value in that because like when we look at like it's called Hobfall's five, which is the five things that people need after trauma. And the very first one is safety.
Yeah. Yeah.
So, and I wish that I had taken this approach. I remember years ago, I had a person who hyperventilated on my table because I was working on their neck and they had some childhood trauma around that. So like looking back on that, it ended up like the person came back and we worked through it and everything was fine and eventually could do a full neck treatment with the person. But to have that approach of, well, why don't you put your hands over mine and guide me to make it feel more safe for them would be like, it contributes towards shared decision making and trauma informed practice and all these other things. So that's an amazing approach that I wish I would have thought to use or known to use back then.
Yeah.
Yeah.
You know, on my website, I have a page that I call the peer-to-peer mentoring videos. And essentially, it's just interviews, Zoom interviews I've done with speech pathologists, but there's a couple massage therapists, there's some dental hygienists who do myofascial work, et cetera, some voice coaches. And basically, it's about I did these videos to give newcomers to the work at least a framework. Okay, the seminar was interesting, but how can I apply this in practice? So that's what these videos are directed at, all these different patient profiles, et cetera, and how they started applying this work. But I did an interview with, so I've taught in Athens, Greece a couple of times, and I need a translator there. And my translator has always been a speech pathologist who is easily bilingual, and she's provided the translation for me. But interestingly enough, she's also a psychotherapist, right? Pretty interesting blend there. And at the second time I was in Athens last year, she was actually not just my translator, but I was doing laryngeal demonstrations on her as well. And I asked her that question, Elpida, does this feel safe? And boy, talk about needing to pause for a minute to really reflect on that question. And she talked a little bit about it, but then we talked later and we decided to do this peer-to-peer video on it. She talked about that question. Does this feel safe? Do I feel safe? What does safety mean, right? Because we've got the surface level. It's like, no, you're not going to hurt me. But then when we start reflecting, you know, from that psychosocial perspective, that question of safety, it was just a fascinating one that we talked about during this interview. And if, you know, if any of your listeners are interested in that, go to that that peer-to-peer video, because I think it's pretty insightful, and it's got little to do with manual therapy, and it was more with the dynamics of the actual interventions in the one-on-one that we're doing with a patient.
Cool. Cool. So I wonder how much you use shared decision making when it comes to things like recommending home care.
Oh, it's huge. Like,
Yeah.
well, okay, so let me go to exercise for a second. There are really good studies out there that if I can align my recommendations with what the patient likes to do,
Yeah.
I stand a better chance of them doing it. I could feel that, okay, core stability, Pilates is what this person need, and they're thinking, oh, I tried that. I hated it. So that's where the intake comes important. I'll ask my patient, what sort of things do you like to do for exercise, for activity, for enjoyment? Not to shame them into, well, I don't exercise that much. That's not what I'm talking about. What do you like to do? Right. And then I'm going to make my recommendations based somewhat on, not somewhat, but based on what they said to me. And that comes the same for home treatment, for self-stretching, etc.
Yeah.
What's your day like? Do you have 14 little kids at home that you can't lay on the floor and do what I'm asking you to do, or a dog that's all over you, right? So what I don't want to do is make it such a chore that I'm dooming it to failure before they even started. And I think that's one of, at least from a physical therapist perspective, is we have a tendency to overload patients with homework. And some of us, yeah, give me all you got. I want to get better. But here they go home with 4 pages of exercise that we tell them they need to do this 3 times a day. And it's almost like a recipe for failure. So be realistic. And to me, realistic is do 1 or 2 things that you, my patient, find most impactful, right? And then if you want more, we can also do it. So to me, that's how we incorporate both shared decision making as well as a real brutal understanding of the human condition, that the more I give you, the less chance you're actually going to do it.
Yeah. And I wonder if there's been any shift that you've made as far as like just understanding contextual factors of treatment. So with looking at the shared decision making model, has it changed like how you set up your treatment room or any of those kind of things that we know those contextual factors can be contributing
Hmm.
towards better outcomes with treatment?
That's a really good question. It's one I've never really pondered because I mean, I think this is my fifth or sixth office space, and it's full of tchotchke, as a patient of mine call all sorts of stuff and knickknacks and souvenirs. Um, but no, you know what? To be honest, I've never really given that any thought in terms of making sure that, it's arranged accordingly for contextual factors, and that's an interesting thing that I need to ponder.
Yeah, and I don't know how shared decision making would alter the setup of your room or anything like that, but I'd
Yeah.
be interested to see if there's some research out there on that.
Yeah, well, I know, certainly there's aspects of agreement, right, in terms of the music I play, for instance,
Yeah,
right?
yeah,
I was taught, well, you never want to play music with words in it because then patients are singing along in their head versus going deep into the emotions. But it's like, screw that. I'm in this room for 8 hours a day. I like to play music that I like, right?
yeah.
To a certain extent. But I also, I've modified that based on patient complaints, if you will, or preferences, and it's always on shuffle, so it's not like a continuous drone to somebody. I mean, that's just a real small case that I'm guessing a lot of your listeners here do as well. But even that sense of no, never play music that has words. Aren't I inserting my biases? Aren't I trying to manipulate the patient by sort of using that as one of the contextual factors that I set up? I don't know. It's almost like a never-ending questioning process for ourselves and our patients that I think is a useful one. But eventually we got to get them on the table and work with them. But you're right, the environment that we set up is really important.
Yeah, I know. I used to have one of the clinics I used to have that I worked at. I had Sirius XM satellite radio in the treatment room, and I there was one person that came in every time. I'd walk out of the room, they'd be on the table. As soon as I walked back in, they'd be like, "80s on eight, put 80s music on." And then another person that was like, "No, I want to listen to heavy metal." I'm just like, "Okay, whatever you want to listen to, it doesn't
Exactly.
matter to me." Yeah,
Exactly. Yep.
yeah.
Yep. Yep.
And one of the probably like the final big thing I'd love to touch on is how much of a difference, and I know it's going to be a big difference, but I love the topic of therapeutic relationship, and I'm just curious. Since you've started to implement the shared decision making model, how much do you think therapeutic relationship has improved compared to when you weren't using it?
I think, well, again, we can't be objective with ourselves, right?
Yeah,
We have a bias. Um, I think I understand therapeutic relationship much better. I think I've learned ways to leverage it, to maximize it, to optimize it, to not provide a fracture in the therapeutic relationship. How much, that's a real hard one because a lot of my evolution has moved into more understanding those psychosocial elements to begin with, that even without knowing the therapeutic relationship and all the qualities of it, it's probably improved to a certain extent. Again, I hate to be overly heavy with some of these papers, but there's a lovely, very old paper that I think a lot of massage therapists, physical therapists, et cetera, should really take to heart. It's older than me. It was published in 1957, and it was published by a psychotherapist. Carl Rogers, famous psychotherapist, he was asked to present a paper at a psychological conference that, based on historical reports of the time, got him ostracized from his profession,
Wow.
which really resonated with me because when I started speaking out, I got ostracized from the myofascial release perspective. So there was a bit of a kinship there. But what Rogers wrote about in this paper was the prevailing belief in the time in 1957 was that the choice of the correct modality was key to psychological change. That if a person presented with a certain psychological problem, the choice of the right tool or modality was key to change. Does that sound a little familiar today?
Yeah,
Yeah. And what Roger said is the choice of the right modality is nowhere near as important as the relationship that we establish with each individual person. And to me, in a nutshell, that's exactly what we're trying to accomplish here. It doesn't matter whether you use an MFR, trigger point, or roll finger, whatever, right? It's trying to build that bond. And by the way, that paper has been updated so many times by across the spectrum of profession, including a paper I just found by Eric Purves, another Canadian therapist who you're
yeah,
familiar with, who he and Robert Liebert wrote a paper
yeah,
on knowing and those aspects of the therapeutic relationships that are really important. And I think we should learn more about that. That maybe it's our tool that's less important than how we apply that tool, not to the tissue, but to the human being.
absolutely. Work on those human skills.
Yeah,
Yeah,
exactly.
yeah. Well, I think that's a good amount of content that we covered there. I really appreciate you coming on and sharing your knowledge around this. And I know that there's things that I'll be able to take away from this, and I'm sure lots of other people that are listening will have some takeaways as well. And I'll go to your site and link that video you were talking about into the show notes.
Got it. Great. And Jamie, it's been a lot of years since we had a conversation, so it's good to catch up with you as well.
You as well. Really appreciate it.
Yep, no problem.
All right, take care.
Bye.